Good morning. Welcome to the 4th Annual Vattikuti Innovation in Medicine Summit. Many of you traveled from over a dozen countries to be here. On behalf of our foundation, thank you for your time and effort. Travel's never a given, especially in these uncertain times, and I want to thank everyone here for making the trek. I'm encouraged to see many returning faces and equally excited for all the new ones. For those of you who are not familiar, my name is Abhi Vattikuti with the Vattikuti Foundation. The foundation was started by my parents, Raj and Padma Vattikuti, to be a catalyst for societal change and improvement. Our core mission is simple: to find promising technology, treatment, curriculum, or process that improves on the way things are currently done, and then to expand the knowledge base and ecosystem around that until the new way is no longer the new method, but the best method. Our programs cover diverse domains like AI academies, disaster relief, last-mile banking, rural reproductive health, and of course, building global capacity for new medical treatments. Our Innovation in Medicine Summit exemplifies this mission. Many novel and first-time procedures previously presented on this stage are now the standard of care in their specialities. I want to thank two groups who have made this possible. Our wonderful Vattikuti Foundation team, who has labored day and night for all the small and large details in order to make this happen. And of course, I also want to thank the presenters and participants today. What you'll see on stage is a small part of the overall submissions we have received. We're excited not only to introduce the technology of tomorrow, but the academics, practitioners, and technologists who are making it happen. At the Foundation, we're very proud of our role, but ultimately it is that of a facilitator. Progress and adoption comes from everyone in this audience lending their time and attention to events like this. Thank you again for all your support, and let's kick things off.
For nearly 3 decades, the Vattikuti Foundation has reshaped the future of medicine globally. Founded in 1997 by Raj Vattikuti and his wife Padma, their vision was bold. Advanced medical technology should reach every patient who needs it. Now, with over 200 hospitals transformed, more than 500 surgeons trained to world-class standards, and procedures recognized globally as the gold standard, robotic surgery exists today thanks to the Foundation. What started as pioneering work in one field has evolved into many different fields, all with one goal: improving the quality of human lives.
The Foundation sits at the intersection of healthcare, technology, and surgical education. We realize that the whole beginning point is the surgical education.
A robot is only a tool. At the end of the day, all of you make it happen.
We are proud to carry this legacy forward with a new identity. Built on 3 decades of impact, designed for the breakthroughs ahead. One of those breakthroughs is life-changing incision-free brain therapy treatments using MR-guided focused ultrasound for patients experiencing tremors.
The potential of this machine is huge.
The NeuroNext educational programs assemble clinicians, hospital administrators, researchers, patients, and caregivers together. Inaugurated by the Vattikuti Foundation, the clinical teams travel across India, including New Delhi, Kolkata, Mumbai, Bangalore, Rishikesh, and Ahmedabad. 2 institutes have been established: All India Institute of Medical Sciences and Christian Medical College, with Christian Medical College already functional. The Foundation has also initiated hands-on workshops globally, highlighting the emerging use of AI in surgery through a partnership with Orsi Academy. Advanced treatment technology changes individual lives, but transforming entire communities requires transforming opportunity itself. In Andhra Pradesh, the Kalibo AI Academy, launched in partnership with state government and industry leaders, bridges theoretical education and workforce readiness. Opened in October 2025, the program is on track for over 500 graduates within 2 years, teaching Gen AI fluency, real-world project delivery, and providing industry mentorship.
You can create a lot of innovation in this marketplace. Think always innovation, innovation, innovation.
This is the Vattikuti approach: sustainable ecosystems where education, technology, and collaboration converge. From non-invasive neurotherapy in rural India to medical students on international stages to AI-skilled graduates launching new careers, the Foundation operates across the entire healthcare and education continuum. As medical technology evolves, so does the Foundation's mission. But one thing will never change: the Vattikuti Foundation's commitment to advancing education, technology, collaboration, and access for all. Because meaningful progress happens when we learn together, challenge assumptions, and push boundaries. Better tech, better training, better connections. better patient outcomes. A healthier world fueled by the Vattikuti Foundation.
Good morning, everybody. I hope you are as happy to be here as I am to see all of you. It's so good to see old faces and new faces. We've been communicating for so many months, so it's finally nice to see all of you in person. Before we get started, I have a few housekeeping things. So I just wanted to share a few things. This sign is on everyone's table, and on the back, facing you, there's two things. How to ask a question to a moderator. On the screen, for every session, everybody's moderator's name will be listed. So if you have a question and pretend I'm moderating, you can scan that code, look for my name, and start a chat, and then you can send me the questions. And then the moderator on the stage will be able to see all of them. The second thing I wanted to point out is the Wi-Fi information. The network and the password are here listed, and we have them posted kind of all over the room. So if you ever need them, that's where they are. Another important thing are restrooms. If you didn't see them, when you go to the lunchroom and the breakfast, if you continue going down that hallway, that's where they are. Today for lunch, we'll have a working lunch. So when it's lunchtime, we will exit this room right where these paintings are, and there will be tables set up for lunch. You can grab your bag and come right back in, and then we'll continue the meeting. But dinner will be right here in the same room where we had breakfast. Tomorrow, breakfast will be in the same room, lunch will be in the same room, and tomorrow dinner for our awards ceremony will be right in here. So you just have to keep coming to this floor the rest of the time. So that should be easy. And I'm going to now ask session, one more thing. As your session, it gets close to your session time, we will send you a message on FeedLoop saying that it's time to come to the front row. So these tables right here in the front, we would ask you to come before your session starts so that as soon as the session is done, they will exit and then you can enter the stage. So I would like to welcome session 1 to come to the stage now, and welcome and looking forward to it.
Hello, good morning, everyone. I would like to thank the Vattikuti Foundation for this great opportunity to be here today. My name is Niki Rashidian. I'm a hepatobiliary surgeon at Ghent University Hospital in Belgium, and I'm also Director of Education at the Orsi Academy. So it's a great pleasure and honor to be here, and I will be moderating this session together with my colleague who will be introducing himself.
Hello, it's a pleasure also for me to be here. This is the 4th year I'm attending this meeting. It's a pleasure to moderate this session. I'm Daniele Amperora, coming from Turin. I'm an associate professor of urology, and together with Nikki, we will moderate this session on mainly focused on AI. So maybe we can start with the first speaker. Nikki?
Wonderful. The first speaker is Dr. Andrea Moglia from Milano, Italy. He will be talking about mini-GPT pancreas for pancreatic cancer diagnosis. Andrea, please, the floor is yours.
First of all, good morning to everybody. I'm very happy to be here. I'm delighted for this invitation. I just want to thank Vattikuti Foundation and all the organizers for organizing this event. It's my second time at the Vattikuti meeting, and today I'm very happy to talk about multimodal artificial intelligence to improve pancreatic cancer detection. And I don't know if you know it, but 2026 marks the 25th year of the first robotic pancreatic duodenectomy ever performed in the world. It was done by Dr. Pier Giulianotti in Italy, and now he is in Chicago. Next slide. This one? Green is to go. Or green? And then red is back. Okay, fantastic. Thank you so much. I don't have any conflict of interest to declare. And so, you know, pancreas cancer is very aggressive, and it has the lowest 5-year survival rate in the United States, according to the latest statistics. And about 50% of tumors smaller than 2 centimeters are missed by computed tomography, even by expert radiologists. And you know, medicine, by definition, is no single domain. If you want to make an accurate diagnosis of a disease, you need to process data from different areas like radiological images, EHR, clinical reports, and so on. For this reason, multimodal AI could be very helpful in the diagnosis of a disease like pancreas cancer. Why? Because we can combine images like CT scan, text, and even other type of data. However, there are some challenges in building a large data set combining different types of data. Because at the moment, there's no data set of the same scale as in the case of natural images. Second, if we want to annotate a data set, we need experts to perform the annotation. And this is costly in terms of time and, of course, money. And also because we must comply with security laws like a GDPR in Europe. For this reason, a potential solution could be take a general-purpose multimodal large language model and fine-tune it on a public data set. And this is what we have done. We took a general-purpose multimodal large language model called MiniGPTv2 and fine-tune it using public data set. Our idea was to build a sort of chatbot where we can send a CT scan and a text asking, for instance, could you locate the pancreas in the CT scan? Is there a pancreas tumor in the CT slice? And finally, if there's a tumor, could you locate it? And this slide, you can see the graphical interface. It's a sort of ChatGPT playground interface where you can send the CT slice and a text prompt. The output is a text which corresponds to the coordinates of the bounding box, which is automatically overimposed to the original slice. And this gives us the location of the organ. We can do the same also for the pancreas lesion, for the tumor lesion, sorry. When we fine-tune our model on the public NIH and MSCD dataset, we found an accuracy about 60%, which of course is not enough for a clinical application, but it's better than the most recent model, like the GLM family. And this underscores the challenges in reaching high accuracy in pancreas imaging. You can see here a couple of examples. In green, there's the ground truth, which is the correct position of the organ, and in red, the prediction of our model. For pancreas tumor classification, the results were much higher because the task was easier, and again, the results were higher than GLM family and UMIT more recent models. Finally, for tumor localization, the score was lower, around 28%, because the metric we used, intersection over union, is very strict, and if you make an error of one or few pixels, the metric simply goes down. And this is also due to the fact that pancreas tumor is very small and takes few pixels on the image. And finally, on the abdomen CT1K, which is a multi-organ data set, the accuracy was around 70% for the pancreas, for the all four organs, which is again higher than GLM family models. And finally, we asked a group of 10 expert surgeons from Italy, UK, and Singapore with about 6 years of experience as first operator in robotic surgery to rate our system using a 5-point Likert scale. The results were very good for identifying missing lesion and for surgical planning, and also for standardizing diagnosis. However, the highest scores were reached for the potential of this system as a training tool of young radiologists. In conclusion, MiniGPT Pancreas is the first AI medical educational tool for young clinicians, and in the future, with continuous improvement of AI algorithms, AI tools may improve the diagnosis of even small pancreatic cancer, smaller than 2 centimeters, which currently are missed even by experts. And this would be important because early diagnosis may translate to better patient outcomes with an impact on cost savings for national healthcare systems. Thank you so much.
Thank you. Let's now move to the second speaker. That is Dr. Federico Piramide from Turin, San Luigi Gonzaga Hospital, that will present a study titled Exploring the Metaverse, the New Way to Guide Surgical Planning. Please, Federico.
Good morning, everybody. Thank you, Daniele, for the introduction. It's an honor and a pleasure to be here today presenting the results of of our group study about the metaverse. Actually, what is the metaverse? As you know, in the last years, we have seen the introduction of 3D virtual models and 5G technology. And this led to the introduction of this concept of virtual reality called metaverse, which actually is a fully immersive digital space shared by different users. To realize the metaverse experience, we need a digital environment with the possibility to customize the environment and the avatar of the users, and where the users can upload a 3D virtual object, such as a 3D model reconstruction, and then by using devices such as a laptop or head-mounted display, the metaverse can begin. We already tested the application of metaverse for the surgical planning during an international meeting, and in particular, surgeons and moderators discuss the 4 predefined 3D model phantom that you can see in the slide, trying to plan the surgical strategy according to this reconstruction. Despite promising, the lack of customization of the models was one of the main limitations arised by the users. So we push forward in this direction, and we develop a new metaverse platform where, with a more immersive environment and a new personalized avatar with the possibility to modify users, the avatar of the users according to their physical appearance. We enhance the handling of the model, and we upload just one single model that can be modified according to surgeon preference, as you can see in the video, by decompose the model, modifying the transparency, removing the tumor, and lastly, the possibility to have the metaverse window available for consultation during surgery by using the Tile Pro. So during the different steps of the surgery, the surgeon was guided by the moderators that were still in the metaverse. So aim of our study was to investigate the use of metaverse for surgical planning, and we evaluate the concordance between the surgical planning defined in the metaverse with the surgery actually performed, and of course we evaluate the usefulness of this technology via a dedicated questionnaire. In the video, you can see a 3 centimeter small renal masses that, modifying the transparency of the model, the surgeon is able to identify the artery feeding the tumor, so to plan a selective clamping. Furthermore, looking better at the intraparenchymal structure, surgeon identify a big vein which is actually at the bottom of the tumor bed, and so the planning strategy was to perform a pure enucleation resection with a sutureless technique. As you can see here, the ultrasound confirmed the presence of the vessel showed by the 3D virtual model, and the surgeon started with the selective clamping that was confirmed as by the use of ICG. Then he starts with the resection phase, try to gain as soon as possible the pure enucleation plane in order to spare the largest amount of tissue, but also to be sure to reach exactly the plane decided during the planning, and as you can see here, to be able to spare the vessel that was seen before, and so to realize a very minimal impact surgery. As you can see here, also removing the clamp, the vascularization was spared. We discussed 15 clinical cases during an international meeting and involving 38 users across 5 distinct physical locations. We do not record any technical issue, and the preoperative plan strategy was effectively performed in reality in all procedures, and we recorded high level of user satisfaction, especially for the immersive environment, the customization of the model, and the usefulness for surgical planning. So in conclusion, we can say that our new metaverse experience showed to enhance the surgeon perception of the anatomy, to represent a valid tool for surgical planning and preoperative clinical case discussion. And in the future, we should focus in its application in surgical simulation and training. Thank you very much for your attention.
Thank you so much. Beautiful presentation. The next speaker is Dr. Nasrin Al-Aloui from Spain. She will be talking about leveraging AI to enhance outcome research. Please, floor is yours.
So, hi everyone. I would like to thank, first of all, my colleagues to presenting me, and also the Vattikuti Foundation to organize this great event. So, let's get started. The title of this presentation is Leveraging AI to Enhance Outcome Research. I'm sorry. So, in our company, we built a system that have improved our processes of data collection, and we are happy to share it with you. So, let's discuss a little bit the context. Research depends on data, and most of it is embedded in free text. Clinical documents have very important data, but the process of extracting this data and structure it within data sets, it's very time-consuming, and it gets very tedious. So we developed We developed a tool that is called Eurodatics, which is based on artificial intelligence, specifically LLMs, large language models. These LLMs, they read the document, they understand it, they extract the data we need within our data sets, and they place it within these Excel sheets or database or whatever it is. So they perform this automation, and then the researchers will be able to perform their research without having to invest time collecting the data. So let's take a look over an example. As you can see, this is a document. It's a micro-ultrasound report for prostate cancer diagnosis. And our researchers within our company are interested in learning about the lesions, like the location, the Primus score, and the type of lesion, and so on and so forth. In the right side of this slide, you could see the columns that our researchers are interested in. The same applies to the biopsy report. Within our company, we perform biopsies with different techniques. And we would love to compare these techniques, so we would love to extract many data. And below the presentation, you could see the data we target, the Gleason score, the location of the cores, how many cores were positive by each method, and so on and so forth. And now let's see a demonstration. As you can see, there is the tool, and we have to select the folder. I'll ask the moderator to turn on the video, please. Just give it a click. So we have to choose the folder where you see the PDF, and then we have to execute the program. Once executed, after 2 minutes, normally the execution will be finished. And we have to export the data to see it in Excel file. We save it, and now you can see the Excel file within this folder. When we open this file, you could see all the data is extracted and placed where we want. Okay. So let's discuss a little bit the results. To read these documents, we used to invest like from 20 minutes to 30 minutes to understand everything, you know, because we used to cross the data from different reports and do comparison. So yes, it was very time consuming. With this tool, we didn't invest any time because the tool do the work itself, you know. We choose only the folder, and we as a human, we don't invest any time in it. And the work that we used to do in 1 week now is done in only 1 day with this tool. So that's it. Thank you so much for your attention, and that's it.
Thank you so much. So let's move to the last speaker. I asked Dr. Jay Kohara to come on the stage from Drexel University of Philadelphia.
Good to be with you all. I'm Jake O'Hara. I'm the research fellow from Hackensack University Medical Center.
In this video, we will be discussing predicting clinical outcomes using machine learning. These are our disclosures. Up until now, we've had no real objective measures for what's happening during surgery other than things like case time, blood loss, and anesthesia parameters. This is why Intuitive Surgical is launching a new technology, the Insights Engine, which allows surgical cases to be split up into steps and overlaid with objective, robotic, kinematic data. Our objective in this study is to assess the pilot version of this application using data from our institution's IRB-approved prospective prostate cancer database, and to see if this application can predict erectile function and urinary continence outcomes based on these objective metrics. First, we looked at patient factors using this application. On the left, we see which patient factors the application predicted to be most important for erectile function trend. On the right, we've laid out preoperative prostate size and patient age side by side, and we see the same result we would expect based on the literature. Decreasing preoperative prostate size and decreasing preoperative age are associated with improving erectile function postoperatively. Here we see more examples of signals that we're getting from this machine learning application on the objective performance metrics when looking at individual steps of the procedure. These are early signals with not a lot of data, but they are excellent examples of what this application is already predicting. The first thing to point out is how the surgical steps are weighted against one another. The application independently predicted the 3 most important steps for erectile function were the right and left pedicle steps and the posterior plane dissection, which clinically makes a lot of sense for how we think about erectile function preservation. On the right now, we see the OPIs predicted to be of greatest importance for erectile function recovery. Some of the significant OPIs include increasing bipolar path length during the right pedicle dissection, smoother scissor movement during the posterior plane dissection, and smoother bipolar movement during the left pedicle dissection. When looking at the important OPIs for return to continence, significant OPIs included decreased workspace volume during the anterior bladder neck dissection, decreased forceps path length during the vesicourethral anastomosis, and decreased forces during the apical dissection. Of note, the application did not yield an F1 score for the apical dissection step, though we would expect this step to be of significance for continent function after prostatectomy. In addition to the DV5 allowing us to look at the objective metrics already mentioned, we're also able to measure forces during surgery, which has also not been a possibility before now. When taking a look at our key steps for erectile function, we can see that forces may play an important role in postoperative erectile function recovery, and we're able to take this right down to the patient level for a closer look at what we're seeing in the data. On the right-hand side, we're seeing a comparison between 2 patients, one who had higher forces during the left pedicle step and whose erectile function has not improved, and one who had lower forces during that step and whose erectile function has improved. Now let's take a look at their surgical video. On the left, we see the patient with higher forces in the left pedicle step. Notice our plane not separating easily, which requires the operator to place more traction on the neurovascular bundle with the non-dominant instrument. On the right, we see the left pedicle dissection in the patient with lower forces. Notice how the surgical plane develops with much more ease, which leads to lower traction being placed on the tissue. In this way, we're able to contextualize the data obtained from the insights engine and can see how tissue quality may play a role in erectile function outcomes for these two patients. In summary, the Da Vinci 5 platform is allowing us for the first time to easily collect objective surgical performance metrics and force data. Although this machine learning platform is still in the development stage, it is offering the ability to make predictions on patient outcomes based on objective data. In this study, we collected 86 robot-assisted radical prostatectomies with objective surgical metrics and assigned 24 patients to our urinary continence cohort and 13 patients to our erectile function cohort. This application gave us the expected finding that decreased patient age and prostate size would be associated with improving erectile function. It also gave us more granular predictions based on the individual steps of the prostatectomy and the objective metrics within each step. Lastly, we demonstrated how access to OPIs and force data can guide further video review of cases in a targeted way. This is one of the first times an analytics application has been used to predict clinical outcomes and assess patient factors in an automated and objective way using robotic kinematic data in addition to patient data. This work builds the foundation for surgeons to use predictive analytics to better understand patient outcomes.
We can open these 10 minutes of discussion. Nikki, if you have questions from the audience.
Yes, I have received two questions for Dr. Moglia. And the first question is that can the model be applied to the ultrasound as a dynamic real-time investigation?
So thank you for the question. Well, of course, you can apply the same technique to other imaging modalities like MRI or ultrasound. Anyhow, we need to design a customized pre-processing method because ultrasound are different from CT, but we are confident that you can apply to also US.
Wonderful. And the second question is that, is this mini GPT pancreas useful in planning for surgical approach? I understand that now is a binary, is it tumor or not? And they are asking if it can say something more about vascular anatomy, resectable, borderline resectable.
Yes, this is a critical question. Well, for the preoperative planning, I think that it's not the most suitable tool. I would suggest a tool based on segmentation. And we are working also on segmentation pancreas and pancreatic tumor. And the question on vascular is very important because, you know, as a surgeon, you know that the infiltration of the tumor into the pancreas is into the vessels around the pancreas is very important. And luckily, in the past months, it was around October, they released a massive data set with not just the annotation of pancreas or the tumor of the pancreas, but even the vessels around, like the superior mesenteric artery, the common biliary duct, etc. And yes, I think that if we can manage to detect even this small anatomical size, it could be really very helpful. And we are working with a surgeon in North Italy. We are considering writing a grant on this specific topic. Thanks for this question.
Okay, one more question for you from the audience. It's a question and a suggestion. Why not to use historical CT and MRI to teach the AI so you can get more data points and will help you to get the false negatives by expert and AI?
Yes, of course. This is an excellent remark because MRI and CT are complementary. And this was a suggestion or remark we received when we published a paper. And of course, we would like also to integrate MRI and maybe other imaging modality like ultrasound, because sometimes physicians start with ultrasound instead of CT. And MRI is important because you know much better than me, because I'm a technician, I don't have a clinical background, that MRI doesn't have impact of, X-rays on the patient, so it's much healthier than a CT.
Great, thank you so much. I do have also one question from audience to Nasreen, and they are asking what governance framework are needed to ensure that the AI-driven data extraction tools remains compliant with GDPR, and we can make sure that we protect the patient data.
Yes, because we are working with artificial intelligence within our computers, so everything is happening within our computer. We work with open source models, and we execute them on edge, so all the data is kept within the workplace.
Local data protection, of course.
One more question for Jake O'Hara. Can machine learning lead to more patient concerns and litigations?
I think it depends on the application of the machine learning. The way in which we're using it right now, it's more to get early signals on things we can do to improve the training of young physicians, signals for excellence in robotic surgical training. Now, I think if you were to advance that and you start making decisions about hiring practices at institutions based on objective surgical performance metrics that you're getting from these machine learning platforms, and you're kind of applying that to real-time surgery on real patients, then perhaps, if things go wrong, you may have an argument to say, well, let's look at these objective metrics. Where did we land, above or below some of the metrics that we're defining as excellence during surgery? But I think really at this stage, the benefit is having a sense for, okay, where are the experts landing in terms of some of these objective metrics, and how are, young physicians matching up to them, as they develop their residency.
Okay, thank you.
Great. I have also one question. I think it's to Nasrin again, and they're asking that how much time it takes to create a program for each type of PDF report.
Well, it actually depends on the type of PDF and the type of computer you will have. So if you have a small computer with a small GPU and CPU, with small resources, it will take like from 5 to 10 minutes to read an MRI report. But if you have a powerful computer, it could be done in 2 minutes or less. So it depends on the report and the computer you have.
Okay, probably one last question for Federico, just because we are running a little late. Is the use of metaverse cost-effective? And since the metaverse is fading at present day, is this program viable?
Thank you for the question. Actually, we have to imagine which are the potential application of metaverse. Actually, the examples we are discussing today are done during an international meeting, so most of the surgeons are there, but you have to imagine this type of technology for telementoring and teleproctoring, so for clinical case discussion between people that are maybe miles away, so in different locations. I think that you have to consider not the metaverse itself, so not just 3 people with the head-mounted display that are discussing the same case that are, for example, here on the same stage, but you have to think of the potential of the technology, putting together, for example, also an AI-based surgical planning. So as you know, Daniele, we are working on having an AI that actually is driving the surgeon in suggesting which are the best surgical strategies. So if we put all the pieces of the puzzle together, I think the metaverse is something that can help in reaching better patient outcomes. Thank you.
Thank you. Other questions from the audience? Nikki?
Great. Thank you so much. I think probably because of the time, better to close the session and go to the next session, which is already a bit late started. Thank you so much, all the speakers, for the wonderful presentation. Thanks to my co-moderator and also the audience for the engagement. Thank you so much.
Thank you. Thank you so much.
Actually, just stay one second.